Good afternoon and welcome to the 2012 Healthy Minnesota Communities in Action Forum. I'm Tina Morey and I am a member of the University of St. Thomas Healthcare MBA program. In March of this year, our cohort visited Washington, D.C. and explored the ramifications of health reform on communities. Today's program is a result of our experience and our desire to highlight Minnesota's efforts towards community health and wellness. And before I introduce our moderator for today's panel discussion, I'd like to thank all of our poster session exhibitors for their inspiring initiatives and dedication to the health of our communities. I would also like to thank our sponsors, our premier sponsors, Allina Health, Blue Cross and Blue Shield of Minnesota, Cardinal Health, Midwest ENT Foundation, Prime Therapeutics, St. Francis Regional Medical Center, United Health Group, and our scholarship sponsor, Medtronic Foundation. The moderator for today's panel discussion is Minnesota Commissioner of Health, Dr. Edward Ehlinger. Dr. Ehlinger was appointed to his position as Minnesota Commissioner of Health by Governor Marc in January of 2011. Prior to his appointment, Dr. Ehlinger was the Director and Chief Health Officer at the University of Minnesota's Boynton Health Services, a job he held for 15 years. Dr. Ehlinger's dual experiences in public health and medicine serve as a vision for the agency. Dr. Ehlinger believes the future of healthcare depends on crafting a seamless marriage of prevention and treatment services. They are not two separate systems. Please help me welcome Dr. Edward Ehlinger.
Thank you, Tina, and good evening, everyone. I sort of liked it when everybody was around. The displays, the level of energy, the level of noise was very contagious, and it just really highlighted the fact that we're all here really because of the health of our communities, sort of the health of the populations, one of the first part of that triple aim, the population health. And I always say, and you can tell it from here, if it's not fun, it's not public health. And but I'm also finding that if it's not public health, it's not fun, because I think all of those people who are doing just the clinical care, as important as it has to be in the context of their community. It has to be in the context of making a difference in their community where they live and where they play and where they work. And that's what really makes health fun. So if it's not fun, it's not public health. But if it's not public health, it's not fun. And that's what we really need to do, is integrate medical care, public health, social services, education, because they're all part of what we do collectively as a society to assure the conditions in which people can be healthy. So that's why it's fun to see all of these public health people here today at this great session, which it comes at the end of the MPHA, the Minnesota Public Health Association annual meeting. And this is really a nice capstone event for that. And the theme of the Public Health Association meeting was public health. It's for the people, by the people. And this session, which was really nicely put together by the students at the University of St. Thomas, which I think just did a great job, Healthy Minnesota, Communities in Action. And I think that fits in what's been talked about in this room and several rooms around here over the last couple of days, that if we're going to change health in our society, we really have to work on the medical care system. We have to build health reform around that prevention model, making health care balance between treatment and prevention, integrate medicine and public health, and rebalance our investments, because we put a lot, 95% or so on that medical care side, but only about 5% in the prevention side. But we all recognize that whatever we do with the medical care system, it only affects about 10 to 20% of our overall health. It's all of the other things. It's that individual behavior, which makes up about 40%, but it's that individual behavior where? In the context of their environment. How the environment where they live, work, play, and worship affects the choices that they make. So that's why we're here at this Communities in Action, to think about some of the things that we've got at the table here, some of these community activities that really set the stage for the environments, the policies, and the system changes at the community level that help people make the healthy choices, the easy choices. We're going to be talking about how we align community resources, how we put health in all policies, not just the medical care policies or the health policy. It's in all policies. It's in the transportation policy, it's in the food policy, it's in the educational policy. And we're going to be talking about community engagement. And I think that's one of the other pieces that we're going to be hearing about today. So as Al Capp said, it just happens to be Al Capp's birthday today, and he created Lil Abner, and he was talking about Dogpatch, USA, Dogpatch, Kentucky. He said, any place that anyone can learn something useful from somebody with experience is an educational institution. And so I think we have these communities where we're going to learn a lot from the experiences of people in those communities. They may not be Dogpatch, but I think we're going to learn a whole lot. And we've got some great presenters to give us 3 to 5 minutes little deal about what they're doing in their communities, and then we'll have a little discussion about what they're learning and what kind of take-home message we can take back from this as we move back into our communities. And so we've got Marc Manley here from do.town, a unique collaboration between the cities of Bloomington, Edina, Richfield, and Blue Cross and Blue Shield of Minnesota. Marc is the Vice President and Chief Prevention Officer of Blue Cross and Blue Shield of Minnesota. We have the heartsbeatback program, the Heart of New Ulm Project, a collaboration of the Minneapolis Heart Institute Foundation, Allina Health, New Ulm Medical Center, and the community of New Ulm. And we have Jackie Boucher here. She is the Vice President for Education for the Minneapolis Heart Institute Foundation. We have the Healthy Communities Partnership, sponsored by Allina Health in conjunction with the George Family Foundation. And we have Dr. Courtney Jordan Becker here, Vice President of the Penny George Institute for Health and Healing, Medical Director of Health Promotion and Prevention, Medical Director of Cardiac. She's got a lot of jobs. She got all of these things. And then we have Ellie Zelke, Allina Health Director of Community Benefit and Engagement. And finally, we have the Hennepin Health Program, Hennepin County's Integrated Health Network, and Jennifer DeCabilis, who's the Director of Hennepin Health Program. So why don't we start, Marc, with you, trying to give you a little overview of what you're talking about and what you're doing.
Good afternoon, everybody. It's great to be here, and I'd like to give you a quick overview of the do.town project. Do.town is a collaborative project to promote healthy eating and physical activity in the cities of Bloomington, Edina, and Richfield. And since we're in Bloomington right now, you are in a do.town at this very moment. Do.town is just one of many community projects that Blue Cross Blue Shield of Minnesota supports, but it's one that focuses on both physical activity and healthy eating. And just like all of our community projects, it really focuses on policy systems and environmental change. So it's really about changing a community in a way that promotes health and healthy behaviors. And that's really where our emphasis is in do.town. And just like all of our other projects, it is a collaborative project with those 3 cities, with Blue Cross and with Bloomington Public Health, the local health department that serves those 3 cities. The Bloomington Public Health is a SHIP grant recipient, so they're doing some terrific work that really serves as a foundation for what we're doing, and do.town is a complement to the work that's going on in those communities through SHIP. So let me tell you, there's 3 key features of do.town that make it powerful, and I'd like you to be aware of them. One is that it has very, very strong city government leadership. This project started because the mayors of those 3 cities came to Blue Cross and asked if we could work with them to promote health in their communities. And they committed to providing their time and their leadership and their connections. And they have come through on all of those and made our project much, much easier to accomplish its goals. The second important feature of do.town is intensive community organizing. We've hired organizers who are, actually some of them are here, but they are in the communities of Bloomington and Edina and Richfield. Unlike many other public health projects, we are finding and identifying individual citizens in those communities who have an interest in these topics, getting their contact information, getting them hooked up with other people with similar interests, and helping them organize projects at the very, very local level to improve their communities. So it's meant that our community organizers, in addition to finding people's names and finding interested people, are getting people together in supper clubs, are attending existing meetings of community organizations, are finding speaking opportunities, are bringing people together to really get change made at a very local level. I'll give you one quick example. In the city of Edina, in some lower income high-rise buildings, we organized a meeting of people in those high-rise buildings. There's about 1,000 people living there, and many people at that community in those buildings said that they really didn't have any place for their children to be physically active. There weren't any playground equipment. There was no playground equipment nearby, except a few blocks away at a school, but there's no sidewalk and a number of dangerous crossings involved in getting to that school. And so really they felt like there was no place where the kids in these buildings could play. And so we've identified the people who had those concerns, brought them together, they collected names and got support from other people in their building. They found a champion on the city council, and they are now working that issue through the city council, and we expect in very short order to see changes in both the locations of playground equipment and some change in how traffic is handled in that area. And that's exactly the kind of thing that we're seeing when you really work with individual citizens. You're seeing very, very local, not just local at a community level, but local at a neighborhood level or local at a building level interventions to make communities more walkable and bikeable and to increase the healthy foods that are there. The third component of do.town that I'll just mention is strong public relations. And sometimes I've known in my own public health programs at times, people in the communities where we were working didn't even know the program was there. And so we've spent some resources trying to make sure that people know this project is there, using standard public relations techniques that are often used in the private sector, but not always in public health work. And I think for a project like this, it relies on community involvement. People have to know it's there, they have to be excited about it, they have to want to get involved. So that's the importance of public relations work. So the project's only about halfway done, but we're seeing a real acceleration in the number of policy and systems changes in a number of different sectors, in schools and workplaces, and at the community level. People are working on things like master bike plans, farmers markets, community gardens, bike lanes and the school food environment, and we're seeing changes in every one of those areas and real progress across those three communities. So we're learning a lot of things, and I look forward to talking about it more during the discussion session.
Jackie, how about you next?
The Hearts Beat Back, the Heart of New Ulm project is a 10-year project to prevent heart attacks in New Ulm, Minnesota. So our long-term 10-year goal is preventing heart attacks, and our 5-year goals are more focused on addressing 9 modifiable risk factors for coronary heart disease. The project is in New Ulm, which is about 90 miles southwest of the Twin Cities. It's statistically the most German city in the US, and I know we joke a lot that the 4 food groups are beer, brats, butter, and cheese. So we have a lot to work with in terms of improving our food environment. It's a population-based prevention demonstration project that engages the community. So we not only base our project on the best available evidence from projects like the Minnesota Heart Health Program and the North Karelia Project, but we also base it on our community's levels of risk and preferences. We have a 36-member steering committee that helps guide the project in terms of our strategy. And that steering committee includes people like the Brown County Public Health Department, the city, businesses, schools, the Chamber of Commerce, local healthcare providers. We kind of engage all areas of the community. Our interventions are very broad and focus on 4 key areas. So we have interventions in the work sites, healthcare, and in the community, and we do a lot with environmental reengineering. I think some of the innovative aspects of the project are that it's funded primarily by the healthcare system, that we have great engagement from the community. After the first year, we had a 94% awareness, and subsequent years have continued to have a 94% awareness of the project throughout the community. I think the use of the electronic health record as our primary surveillance tool, I think that's one of the innovative aspects that maybe they didn't have in the Minnesota Heart Health Program or the North Karelia Project. And when we looked in 2009, we did screenings in the community to try to help inform the data that was in our electronic health record. And from that data, so we had about a 40% participation rate with no incentive for people to show up and do the screenings. from that data, along with data in the electronic health record, we did our community diagnosis. And from that community diagnosis, we really identified 4 key areas that we would focus our future interventions. And those 4 key areas were the overweight obesity rate. We had about a 73% overweight obesity rate. High prevalence of metabolic syndrome, about 34%. Low fruit and vegetable consumption. So we really only had about 19% of the population meeting recommendations to eat 5 or more servings of fruits and vegetables per day. And there was a very low utilization of preventive therapies like aspirin, statins, and blood pressure medications in those at highest risk for having a heart attack. So then we began implementing our interventions, really trying to focus on all levels of the social ecological model. And then from there, in 2011, we did an assessment to see what our progress was. Are we reducing those 9 modifiable risk factors? And basically, we've had great engagement throughout our programs. Our 2011 survey showed that 60% of the people participated in some type of intervention that the project made available, which is a very high percentage. And as a result, we've seen some statistically significant changes. We have 3 posters here, so I won't go into all the data from those, but just a couple examples. National trends for blood pressure are that uncontrolled blood pressure rates have been stable over the past decade. And based on our electronic health record data, we have almost a 3 percentage point drop over the 4-year period in uncontrolled blood pressure. Nationally, data shows a 1.2 percentage point decline in uncontrolled cholesterol, so cholesterol is higher than 240 in 40 to 59-year-olds, and we've seen a great decline. Our HANU electronic health record data shows a drop of about 2.2 percentage points for the population age 40 to 79, so at a population level. And then we've also seen that we've been able to stabilize our obesity rate, whereas nationally, we know there's been an increase of obesity rates. And so we think we're making some great progress. We continue to use the community to inform our strategy, and we'll look forward to talking more about what we're doing in New Ulm in the discussion.
Okay, can you hear me? All right. My name is Ellie Zelke. I'm the Director of Community Benefit and Engagement at Allina Health, and Courtney and I are going to talk about the Healthy Communities Partnership. I just want to set a little bit of context, and then Courtney will talk a little bit more about the specific initiative. Allina Health is a healthcare delivery organization, but our mission, in addition to providing exceptional healthcare when you're sick, is really about keeping people healthy and, frankly, keeping them out of our hospitals and clinics. So we have a whole body of work around community health improvement. I'm really proud of, there's several posters here today that showcase some of the examples of our work. But in terms of context for the Healthy Communities Partnership, we conduct a needs assessment every 3 years, and not surprisingly, obesity and mental health were the key issues that rose to the top. We spent a lot of time, though, in our communities, in dialogues, talking with community residents, key stakeholders about, okay, so great, what we know these are problems, what are we going to do about it? And some of the key strategies or things that were identified related to, first of all, increasing collaboration, partnership, and communication, and really recognizing there are these tremendous community assets already out there. There's a lot of disconnection, and that we're probably not maximizing the benefits. The other thing that people talked a lot about is, I know I'm supposed to eat the fruits and vegetables. I know I'm supposed to exercise. Geez, there's some great improvements in the physical environment, but boy, I need that social support. So how do I build that social network? So we've taken a lot of that feedback and really worked and partnered closely with community residents and with organizations to try to develop strategies to address those. And we've learned a lot through the different programs and initiatives. Healthy Communities Partnership, I think, is a culmination of a lot of those learnings. And I think responds to, there's a quote that I'm going to read from one of the dialogues in the Community Health Needs Assessment. And the question was, what should Allina do? What do you think? So we've identified these problems, what should Allina do? And this person said, Allina should spearhead a movement to connect all of the resources in the community to work together on this. And now we have Healthy Communities Partnership.
What an intro. So yes, that's exactly what we're trying to do, and I think collaboration is really the key. I sit here and think to myself, Jackie and I have worked together. I was down in New Ulm 2 weeks ago. Marc, Manley, and I worked together. I'm part of the Do.town initiative. And Ellie and I have worked together prior to this on the SHIP work that I worked on prior to this initiative. I can't say anything about Healthy Hennepin, but I'm sure it's that we're in there somewhere. But that's where this Healthy Communities Partnership came from. After working on the statewide health improvement program, really having the opportunity to, what would you do with just a little bit more money? What could the health system do to take off on the great work that was done from the state? And really that warm handoff was what we saw was missing, or what we could help collaborate with SHIP, and that the health system needed a better way to connect with public health and with the community, so that in part, that 10% of the difference that we make in healthcare, that could we make that more like 20, 30, 40% if we really did a good job of keeping communities well. So we are working with 13 different rural communities across the state of Minnesota to really improve their wellness. We're not doing essentially any disease detection. We are doing some screenings, but we're trying to do everything we can to get people to understand the behavioral changes that they can do on a day-to-day basis, not just through education, but by making the biological and environmental environment easier for them to do that in. So by all the work that everyone else is doing here, that same type of model, connecting civic leadership, business leaders, the health system, public health, and lay leaders that can really get that done in a community. And the other key point of this is doing it in a sustainable model. Each community was given a sizable amount of money, but relatively small for these large types of initiatives. But we're trying to get it to be so that it's built into that community to then continue in the future. We started this in May, and we are following this from a research perspective as well. So we have 2 cohorts going at this time, and we're looking forward to our 3rd kicking off here in December. So we'll welcome some questions about that as we go forward. Thanks.
Thank you. And Hennepin County will welcome any participation.
Yeah, I know. I'm like, there's something that I can sit on.
We identified in Hennepin County, as the economy was changing, more and more people were seeking safety net services. Tax base was down, so revenue coming in was less, but the people coming in were jumping by leaps and bounds. So we identified a need to bring our system together in a different way, get more creative, because we needed to stretch dollars further to cover more people. And we initiated Hennepin Health in partnership with the Department of Human Services, effective January 1st. So we're about 9 months in. And what we found was that 5% of the population was utilizing 64% of the services when we looked at those that were under Medicaid expansion. So it's our single adults, high poverty levels, so their poverty is 75% or below federal poverty levels, which is less than $600 a month. With those low income levels, there was high churn through the hospitals, through acute care, in our mental health crises, in the emergency departments. And what we found in talking to individuals was, if you think about, imagine your life in crisis, you don't know where you're going to eat tonight, you don't know where you're going to sleep, you don't know how you're making ends meet, there isn't much of a support system in place. Doesn't matter how many times a physician tells you it's important to check your blood pressure, it's probably not the top of your priority list. So we looked at needing to develop a system where basic needs are met prior to healthcare or with healthcare. So if we have individuals whose basic needs for housing, for food are not being met, we're not going to get their attention in the healthcare realm. So in the county, we brought together our health plan. We have Metropolitan Health Plan, our hospital, HCMC, North Point, the federally qualified healthcare center that's operated in the county, and our social services and public health arm, and said we need to start working together. A real key example of that is an individual I met with in a shelter who had 5 different caseworkers, none of who knew the others existed. They had a caseworker because of high utilization from the hospital. The health plan had assigned a caseworker, the shelter had a caseworker, social services had a caseworker, and this individual had behavioral health needs, and there was a behavioral health worker as well. That's really typical in our healthcare system today. And so what we're doing is bringing systems together to unduplicate that, to bring awareness. In the individual's mind, he didn't know we all worked for different people. What he knew is that Joe's telling me to go over here and Sally's telling me to go over here, and I don't really know what to do. So bringing those systems together will reduce costs and improve health outcomes for individuals.
What we launched on with the Medicaid expansion population is right now we have about 6,000 enrollees, and we are partnering those systems together with additional community providers, specifically around behavioral health. The population has greater than 60% are minority status. Greater than 60% have mental health or chemical health issues, or a combination of both. Greater than 32% are homeless or at risk of homelessness, and a significant percentage, I think it's about 30%, with pain issues. So high need population, systems working together is critical. And what we set out to do is reduce acute care visits by at least 10% and increase preventative care by at least 5%. So trying to get up front of getting the social services involved, the public health department involved, getting folks engaged in primary care so that we don't have those deep end service needs. Lots of great learnings from a systems perspective. We have, and I won't in 5 minutes be able to do that any justice, but we have a handout in back that has over 27 initiatives we've already launched. I have a list of 40 plus still to go. So we've got a lot of ability to change the system, but there are great examples of people that are getting pain medications for chronic conditions because they can't have surgery because they don't have a place to live. Well, we're continuing their substance abuse issues by doing so, versus let's house them, and with one individual we were able to do that. Get her housed, get her through her surgery, she had a safe place to recover, she's doing great, she's managing her diabetes because she now has a place to cook healthy meals. There is just a list of those kind of examples of how systems working together have benefit. Our health plan is entering directly into the patient record. That's huge. So when a hospitalization occurs, there's a same-day alert that happens. As soon as the health plan gets that call from the hospital saying we've got somebody here, care coordinator has an alert that says that somebody is in need of help because they have hit an acute care setting. We are able to work with corrections, with the shelters, identifying people that are cycling through services, other individuals with $15,000 in transportation costs because what they believe they need to do when they're not feeling well is call an ambulance. Huge opportunity, easy resolution, able to turn the cost curve, but also get people better care, because what we did with those individuals is train them that there are other options besides the ambulance of how to get them into a primary care relationship and improve their health overall versus onesie-twosie visits to the emergency department. So lots of great synergy. I would say the biggest thing we've learned on systems is way to go, Minnesota. Collaboration has been awesome. A year ago, 2 years ago, people weren't talking to each other. People were holding their cards tight, they were acting as competitors, and it's really just amazing right now. Hennepin Health, we have a health plan. UCare just gave us a grant to partner with them on trying to figure out some behavioral health continuum of care issues for the gaps in behavioral health. That would not have happened years ago. So the ability right now with the health reform initiatives that are going forward for people to partner together has just been amazing, and that's how we're going to do some really cool things. What we're finding from patients is they say there's drops between programs, there's drops between care, there's no continuum. And with this frail population, the ability to navigate those systems and navigate those continuums doesn't exist. So we can put care coordinators in place to help with that, but it really takes those providers to get creative, do business differently, partner together, have those warm handoffs and connections, so it really feels like a seamless system across the communities. Thank you.
Thank you all for those very concise and very informative presentations, and I reflected that I've got some interactions with each of you. Certainly when the do.town was kicked off, I got to dance with the do guy, so that was kind of fun. And in the heart of New Ulm, I was down there visiting, but I'm going down there tomorrow with the Surgeon General for their day of play, and some of my contacts in Brown County were saying this is one of the few events that does not have beer. I understand they give beer at 5K races. Healthy Community Partnership, and this may not be a part of the partnership, but Allina putting their headquarters in Minneapolis, the Midtown Greenway, really blossomed because of that, which is a great community partnership. So when I bike by there, I always tip my hat to Allina for making that decision and changing that community. And certainly Hennepin Health, more from a professional level, where Medicaid dollars are going into that, and how can we save those dollars and use them most appropriately, but also a great example of how you integrate the medical care, the social service, and the public health that are really necessary. And And to start off, three of these presentations mentioned the statewide health improvement program as part of it, and certainly being very self-serving, knowing that we've got the Surgeon General here. You know, what role does that public investment in these kind of community programs play in the development of things like the Heart of New Ulm, or the DO program, or the Heart of New Ulm, and the Healthy Community Partnership? That investment, which is has been decreasing over the last several years. How important is that public investment for the infrastructure for these kind of community health programs? Marc, do you want to start?
Sure. I could spend a lot of time answering that. I'll try to be briefer than my comments were. You know, I think SHIP funding is essential to the do.town project. I mean, in many ways, the SHIP funding sort of forms the whole foundation, and the great work that Bloomington Public Health does allows us to try to experiment with some new things and sort of go above and beyond in those communities. So SHIP is just sort of fundamental in those communities to good public health. I think at a broader level, I think all of us in public health need to spend some time in the next legislative session telling our legislators how much SHIP matters to us. The cuts that occurred in most recently in SHIP were very, very unfortunate, and we all got a glimpse before those cuts of just how powerful it can be to have strong community public health in every county in the state. So I can't say enough good things about SHIP. It's one of the smartest things I think the legislature has ever done, and I think we need to tell them that and make sure they remain smart in the next session.
Jackie or Courtney? You know?
Sure.
Gonna just move.
Oh, I'm sorry. That's what you mean. Sure.
Through the Heart of New Ulm project, we have collaborated with Brown County. So Brown County and Nicollet County received a SHIP grant, and we did receive some funding to work on tobacco initiatives. So in terms of getting providers refer patients into programs and developing a referral source, and developing another grant from them to develop a comprehensive worksite health promotion plan. I think largely Heart of New Ulm has been funded by more the private in terms of Allina Health funding the project, but I think when you think of the healthcare system, in a way it is also a public health system as well, because Allina Health, for example, insures about 1/3 of the lives in the state of Minnesota, and I think you know, they need to go deep in communities in addition to the public health department, so it's a great collaboration. And we did just receive this week a CDC Communities Transformation Grant to help expand some of our work from the Heart of New Ulm project to the rest of Brown County. So really, that continued partnership between the healthcare system and the public health system is really important, along with the collaboration of the community.
Anybody else on that?
I would add that the ability to share resources has been critical through that SHIP funding. So what we often hear from being a large county is the smaller clinics in our community who say we don't have the time, the resources to develop these, and it's that collaboration again of being able to develop educational materials, outreach materials, and share those with a community. The providers in a 15-20 minute visit, if they even get that, are not able to do a ton of education, but having those tools readily available to share within a community is huge.
And I would just add, I can't emphasize enough how important SHIP has been, and I've been involved with it from the beginning. I think what's unfortunate is that what you were starting to see was the environment change, and a lot of that couldn't be measured in the outcomes that they wanted in terms of, again, what we get so fixated, the biological markers, and I think that was where a lot of the emphasis was put, and that's unfortunate because we all know you can't change those very often in a 2-year time span. So, and for me, I think the other elephant in the room is talking about cost, and that we need to utilize that collaboration of a lot of people really have a lot of trust in their physicians, but then from the most cost sustainable model, it doesn't make sense to have that all rely in the healthcare system. So in addition to the great work that SHIP has done, I think for a feasible model going forward, it needs to partner. So.
And certainly one of the pushbacks on the statewide health improvement program was that health is really an individual responsibility for the people who didn't want to continue to fund SHIP. And you're dealing with that. You're doing public health programs in your communities. And how do you make the argument that health is not just an individual responsibility? There's some community engagement, there's some community responsibility pieces in that for your boards or the communities that you're going in with, these things that, like, community gardens and bicycle paths, what do they have to do with health? How do you respond to those critics that say, people just need to take care of themselves?
So, I think a lot of the work that we're doing and a lot of the evaluation around some of the community health improvement initiatives that we're doing in Allina Health is, well, actually, at the end of the day, the numbers do show. And I think at the end of the day, it is really showing the impact that some of the work we're doing, for example, in the Backyard Initiative, that when you are getting people working together, really those social supports, that physical infrastructure, the social infrastructure, that you can have measurable results. I think at the end of the day, that will speak louder than anything else.
So you want data to inform practice and policy?
I think that is,
how
and I
unique.
think the time, Courtney alluded to this too, I think is the amount of time and the ability to measure is a challenge for sure. But I think at the end of the day that's really what will be critical. And as we look at payment reform, that we need to do more of that. So I'm sitting looking at all these epidemiologists that are, so we just do the work, we don't measure it, but I think that's what really matters.
Marc?
I was just going to reiterate, science does help, and repetition matters too when you're trying to convince people, sort of have many voices saying it, and with time people kind of get that idea. And I think it's easier now than it was 10 or 20 years ago. People have seen what happens with smoking when we pass clean indoor air laws and raise the tax on tobacco, so people kind of get that policy and systems changes can impact behavior. So I think we're in a better place than we used to be. But sometimes you have to come back to sort of making it personal for people. And I've talked to a lot of employers and tried to convince them of this idea of changing their workplace to change behavior. And sometimes it's just a matter of saying, hey, have you ever sort of gone away and managed to change something about your behavior? Maybe you started eating a little bit better while you were off on vacation, and then you come right back to the same place where a lot of people are eating badly and there's not any good food around, and you kind of slip back. And just making a very personal story, either about your own environment and your own changes, or even talking to somebody about the attempts they're making to change their health. And sometimes they get the idea that the environment matters.
So all of you come from large systems, and you're looking forward down the road. What's the end game that you're really looking for? What are you trying to accomplish long term? What's sustainable, what's transformational that you're trying to accomplish with these projects, with these efforts?
I guess for me personally, as a cardiologist who sees people in the hospital when essentially it's too late, I am working with an organization where I think we have the ability to really move things upstream and to let people really understand that 95% of heart disease is truly preventable, and make that easier and accessible for them in the community in which they live, and make it sustainable without the financial impact of the health system.
Jennifer?
The county as well is looking at moving things upstream. So right now, healthcare, social services, a lot of it is deep end services. We've funded when people are in crisis. We haven't funded the prevention of getting people to avoid getting there in the first place. And so putting more of our resources and efforts in that prevention end is where we're heading.
I can see what you're doing, Jennifer, is you're integrating, you're changing the payment system. You're changing how you fund all of these services. How are these other groups actually changing the system so that it is sustainable, so that we are really investing in prevention, not just because it's a project, but because it's the way we're always going to do things? How are you making those kinds of changes to really sustain these prevention efforts, these community-based efforts?
Marc and I work together on a variety of efforts, and it's great because we work in this type of environment. We're able to say, well, this is something that we really need to help get coverage from Blue Cross and Blue Shield, and then we're able to work collaboratively that way as well on all sorts of initiatives. So we're certainly working with the payers also.
Mm-hmm. Jackie, any thoughts on?
Sure. I think with the project, we always try to think of how do you innovate, demonstrate, replicate, and then when you're replicating, how do you make it a program that can be sustainable? So who's our community partner that's going to maintain something once we start it? So we've been trying to really implement interventions at all levels of the community. So we have a USDA grant, for example, where we're training more farmers to help increase community supported agriculture, and then more farmers at the farmers market? How do we work with convenience stores, grocery stores, and restaurants to try to make the healthy choice the easy choice, so there's more fruits and vegetables, that the salad comes as your main, you have to request the french fries, those types of things that hopefully, as long as you can work with those partners and show, they have small profit margins, for example, in those types of retail environments. But then if you can create the social norm of eating healthier and get people to order them more often, then those retailers are more apt to put them on the menu, and then it's a more sustainable change. So how do you really look at it from all angles to try to create the most success when you're creating the intervention, so that people are more willing and receptive to make those changes, to make it easier for the person to continue to eat, make those choices, so that it really becomes more of a change in social norms in addition to changing the environment.
So what are the major roadblocks that are you coming up against in any of these projects that sort of interfere with the complete success of these efforts? What are the things that you're encountering? Because there are usually lots of naysayers out there and reasons why you can't do something.
Time.
Yeah.
There's a lot
It's
to be
usually
done.
time and funding.
Yeah.
There's a lot to be done. I think a lot of it is the time and resources. Everybody has to maintain existing systems, and without new resources to move that system to a new model, you're kind of sitting in two worlds at one time. And so, it takes longer than if we could just jump from one system to another. So it takes time to do those transitions.
And I would say it's twofold for us. One, as a health system, we traditionally get paid for people being sick. So that's, we're certainly in the middle of that with healthcare reform right now, and we're not in a place yet where we're paid to keep people well. So it's hard to convince my interventional colleagues in cardiology that, it's not just about stents, that we need to do other things. And then secondly, I think the emphasis on data measurement and outcomes is challenging when you have a limited amount of money. Do you choose to place it in having really great data, or do you choose in putting in interventions that are long-lasting? And that's certainly something that we've been challenged with.
I think the other thing I would add too is, sometimes we just don't know. We don't know exactly what to do. And I think a lot of it is that learning, and it is that reality of trying to, the sort of change things while you're still flying the airplane and figure it out at the same time. So I think all of those complexities, and frankly the incentives too, really remaining for, at least from the healthcare provider side, we do get paid to care for people when they are sick. There is not a financial incentive at this point in time, that's changing, to keep people well.
So, Jackie?
Oh, I was just going to say, I agree with everything people said, but I also think it's really important to that community engagement, because when you get to the point when community members are writing the newspaper and saying, please don't print unhealthy recipes, we only want healthy recipes in the newspaper, or the letter from someone saying, I used to go out and walk and my sidewalks were empty, now they're full, and that's great, but I liked my quiet time. But, but I think you kind of get that community engagement and that pressure from the community, and that really impacts maybe a business's decision to want to do an employee wellness program. It might impact the provider who has the patient coming in talking about it to think, oh, I should do things differently. It sort of starts to have a ripple effect, I guess, in terms of getting everyone on board.
Yeah. That community engagement piece is so important. And how have you gotten the communities that you serve to really take ownership of this? Say it's not just an Allina project or a Blue Cross Blue Shield project, but it's our project. It is our effort in this community that we own, and that we have some responsibility for making it successful and for sustaining it. How do you do that kind of community engagement?
Well, and I think that's sort of, as I mentioned, a kind of a key feature of do.town, and one that we're still learning about. I think in the past, at least some public health projects that I've been involved with, we tended to think about an entire community or an entire county, and people often don't want to take on the individual citizens may not want to take on the entire city changing, or the entire county, or the entire state, but they may care about their neighborhood a lot. And so I think it's finding the people who actually have an interest and helping them realize that they can do something, and that takes very special work and specialized people who are really going to find individual people and get them together and help them decide what's going to happen, and then give them the tools they need to carry out their projects.
This is really the core of our work in community benefit and engagement at Allina, is really looking at this. And I think some of the key things that we do differently now than even just a few years ago I think, first of all, is really starting and recognizing where folks are at and really identifying that intersection between, okay, what are the organizational interests and capabilities? Where can we help folks? Where is the community? Where are folks that we're trying to impact really interested? And what is that intersection? And then really focusing our efforts on that spot, that space in the middle. I think the programs and efforts, again, the Backyard Initiative is a great example where it's not about Allina developing a program and implementing it in the community. It's about working with the folks that we're trying to impact to actually develop the intervention and then implement it. And I think a lot of the initiatives that we rolled out this last year, some of our newer efforts, Neighborhood Health Connection is one, School Health Connection is another. We've changed the design of the programs, the initiatives themselves, where really the person or the community that we're trying to impact is the key actor in helping to define the intervention. And that's a very different approach from us, and certainly is different than the approach when I was in public health school. So that is a big shift for us.
And then, and part of your communities are other agencies, other organizations who are working in similar. So how do you make sure that you align? We have limited resources in prevention. We have limited resources in community development. How do you assure that you align what you're doing with others who may be your competitors, who may not have played with very well in the past? How do you align those things to make sure that everyone is successful, so we're not really wasting any of our efforts?
I would speak to that. What we find is I go into any work group, and if I sit down and we're talking about reducing hospital rates, what the hospital wants out of that discussion and what the insurance plan and what social services want out of that discussion are very different things. It's finding that commonality. What's the common ground that we can all agree to, and how do we get there? That has made us internally successful. And then I would say externally, I just met recently with a group of behavioral health providers, and it was, what are you struggling with? What could we as a county do differently to support your efforts and make your lives and your jobs easier, which we benefit from because our residents are getting better? And how can we find that common ground and common synergy? And that's gotten us a long way.
Can I just add to that? I think in Minnesota, there's a lot of examples of competitors coming together to do good work, and I always call it co-opetition, in that there's often good cooperation, and there's real skills involved in sort of, as you say, identifying the right goal and coming together on the common ground. So I think we have multiple examples of that happening here, but there's still plenty of room for improvement. And sometimes I feel like we have so many coalitions we can't keep track of all of them or be involved in all of them. So we sort of have to be selective about where we choose to collaborate and where we choose just to inform and sort of talk through our partners in understanding how best to interact.
Well, and certainly within the next we're in the midst of some real major health reform initiatives in the state, with sort of waiting for the election to come and see what direction we're going to go. But we know that the ACA was really trying to focus on not just the treatment, the medical part, but also on the prevention. How is what you're doing in your various venues going to inform the policymakers at the state level in particular over the next 6 months about how we should change our overall health system? What things should we incorporate? What learnings have you had that you could inform, Governor Dayton and Senator Han and Representative Gottwald about? This is what you guys need to be thinking about as you're coming up with policies on where we're going to go with health reform.
For us, we're really trying to determine what the evidence-based method is for a health system to be involved in all of this, and I think that is yet to be determined. And so as we go through this, we're gathering data the whole way to find out what are we changing, and again, not just getting focused only on those biometrics, but also on things that influence utilization of healthcare services, which is so important right now. So, I mean, the number one question is how a person rates their health, not how I as a cardiologist rate their health, but how they do. And so that's part of what we're collecting. And if we can change that, we know we'll be able to change how often people utilize healthcare services for unnecessary means. So that will be very informative for us.
I think one of the critical things is alignment of incentives, whether that's between providers, whether that's down to the individual level. So an individual who is incentivized to make better choices, and that improves their lifestyle, is more likely to make those choices. A community who can benefit. So do we turn the cost curve in a certain community, and does that community now, are they able to add more bike paths or more walking paths, which further those gains as a result of doing that? How do we align those incentives from the health plans to providers to communities and to individuals to make those changes. We had a great discussion with the nursing home around a group of nursing homes around difficult to place individuals. So we have folks sitting in hospital beds, medically stable, but they're not the easy ones to take care of. And the nursing homes say, nope, can't take them today. Well, we said, what would it take to get you to take them? And they said, you've got to stop as a system ditching us and leaving them here, because as soon as it gets tough, what the nursing home then does is calls 911, has the ambulance take them to the ED, we readmit, and then they go, we don't want them back. All that is an incentive. So it is, okay, us saying we'll stay at the table, we'll make sure you have primary care backup, we'll put our behavioral health teams in there, we'll allow you to call our mental health crisis team instead of calling the ED. It's getting folks to work together, and when payment systems are siloed, that's much harder to do.
Jackie, you got 95% of the people in New Ulm are go through the clinic there.
Yeah,
And so you have what can you learn from that kind of monopoly in that town with health system?
Yeah, I mean, yes, we're a great petri dish.
It is a great place.
But I think, Heart of New Ulm is a great example of what happens in terms of trying to treat the whole disease continuum. So you really keep the healthy, and then focus on those at high risk and with disease to intervene. But when we talked about it recently, we were thinking, it's really a good example of an accountable care community. Healthcare organizations talk about accountable care organizations, but it really takes a more diverse set of stakeholders sharing in the responsibility to create and improve that population's health to make it sustainable over time. So it's that collaboration between healthcare, public health entities, and the community to really have the most impact.
We're getting near the end of our time. What one thing that you have learned that you'd like to share with everybody out here who's been hearing this conversation, would like to do the same kind of thing with their organization, their agency, or their community? What was one learning that you had that would be really beneficial to these folks to take away from this discussion?
Get your community involved. Get real people telling you what they need and help them get what they need.
Our theory is no is not an answer. It's how do we get there?
I would have to agree with Marc that really getting your community engaged. I know before we even started the project, we talked to the community and that formed that steering committee so that we made sure that we're really, they need to own the project for it to be successful.
I would say the same thing with the community side of things, but at various levels, to make sure that you have the civic leadership, you also have lay leaders, you have physician leaders, nurse champions, everything in between, getting those people all together in the beginning, making sure that any current initiative that's going on in that community that you can springboard off of that really helps to maintain success.
I think the only thing I would add to that is when you've got those engaged folks is then really there's a million things you could work on. Start with those couple of things that there's a lot of shared interest and the incentives are aligned, and I think get some traction there, move forward.
All right, you were very brief on those conversations, so one more thing. What was one thing that has surprised you? What's the biggest surprise that you've had in these efforts?
Well, one surprise we've had is that in Bloomington, Edina, and Richfield, 160-some thousand people, it's hard to get your brand known, to get people excited about a project. It takes real investment. It isn't something that you do by writing one letter to the editor. It takes work for people to really know your project is there and to be excited about it. So the work you do to advertise your project and make people want to be a part of it takes significant amounts of work and money to get it done.
I would say the stinkiness of the onion. So every time we get one initiative under our belt and have some great outcomes, we find that there's 5 other things that we've just discovered that need to be fixed as well. So it's the constant opportunity. There's a lot of work to be done, which is exciting. I think the surprise is always how much opportunity there exists.
That's a hard question. I think, when we started the project, people said, people in New Ulm are skeptical. It's hard to get them on board. You're going to be challenged by that. And I think, they said, but once you get them on board, they're really on board. And, I feel lucky every day that I get to work on the project. And I think the success is because of the great community engagement that we have, the outcomes we have. I mean, I get people sending me things in my home, emailing me their success story. Wednesday when I was in New Ulm, one of the residents had invited me to come and listen, and he wrote and sang in a restaurant the theme song he wrote for Heart of New Ulm. I think that it's just fun to be part of a project that has so much enthusiasm.
If it's not fun, it's not public health.
Yeah.
And I would say my surprise has actually been how excited communities have been. My communities are smaller than yours, Marc. And so that I've been amazed just within 3 months what these folks were doing. At our second kickoff meeting, they had really clearly created a competition amongst each other. And there's one that's near New Ulm that clearly want the Heart of Hutchinson. You know, they want to be the Heart of New Ulm and doing the same stuff. So I think that's so healthy because they're owning it. So I've been surprised that, I don't want to say how easy it's been, but how excited folks have been.
Ellie, anything surprises?
Geez, I don't know. I'm kind of surprised out. All I can say is but in all seriousness, though, because it is a constant learning, and I think there are a lot of surprises, and I think that's been one of our biggest opportunities and challenges. Is like, how do we learn from all of those zigs and zags in the road that we didn't anticipate, so that next time we do it better.
All right. Well, this has been a great panel with lots of good information. Let's thank this panel.